Now, most of our standard diagnostic testing has been thus far catered towards diagnosing hemodynamically significant obstructive stenosis. We are trying to identify the patients that could benefit from revascularization, whether it be PCI or CABG, and therefore, traditionally all along that's been our focus, was to find this kind of plaque which is limiting the flow. And when we are talking about prevention, we want to identify patients much earlier. We want to identify patients with a lower amount of plaque. And the idea becomes it's early detection of coronary atherosclerosis, and we also want to know the atherosclerotic burden. So you know that the non-invasive tests like the treadmill test or that Dr. Nambarajan was talking about. Sorry, I'm trying to see this, if this is going to work. Okay. They all become abnormal over in this category, whereas the most of the non-invasive tests will be normal here. And again, as I said, the idea is to identify stenosis that will benefit from revascularization. Now, the CT is the only technology that we're going to be non-invasively able to identify plaque earlier. And the idea is to, when we are targeting prevention and preserving cardiovascular health, as Dr. had mentioned previously, the idea is to identify it early. Now, CT angiography has been around for nearly a decade and a half, and there's been significant advances in the technology itself. We get the imaging done very efficiently, high-resolution scans with a very low dose, radiation dose, compared to when it first began. And the cost has also significantly come down. In the first decade, in the first era, we were more focused on the degree of stenosis. That was between 2005 to 2010. And then we were also looking at flow parameters, particularly with CT-FFR. We were looking at ischemia, and now the focus has shifted more into understanding more of the plaque composition and atherosclerosis. And I'll present some more data on that. Now, which plaque is which? So you have a tight focal stenosis, that is what, again, we all identify as significant stenosis, can cause reduction in the flow, and as well as diffuse stenosis, diffuse atherosclerosis with a high degree of plaque burden can also reduce the flow. Now, this is the one that you're going to identify quickly with the delta FFR. In any technology, this may not be so easy to identify. However, both cause ischemia. And we always have known that after when the stenosis is more than 80%, we have reduction in flow and ischemic symptoms. But in the moderate range, there's a great degree of variability. And what can plaque characteristics predict that? And that's something we still are researching it and trying to find out. This is standard. Everybody knows this. Normal coronary flow increases 4 to 5 times with any kind of stress, adenosine stress or exercise. Now, diseased arteries, they will have reduced flow reserve. This flow heterogeneity between the normal and stenotic segments is what causes reversible perfusion defect. If it is not heterogeneous, you may not see the reversible perfusion defect. So back in 2008, we were actually looking at this. Now, is the flow reserve and how does it relate to the plaque characteristics, particularly in mild stenosis? And I'll show you 2 case examples. This is a 59-year-old with the coronary CT, and you can see that there's a calcified plaque here. History of chest pain, normal stress test, family history of premature coronary artery disease, has hyperlipidemia and is on Vitarin, a statin. And this is a second patient. And you can see, again, this is a younger patient, 42 years old, again with family history of premature coronary artery disease, hypertriglyceridemia, hypertension, and obesity. And she has a little bit of non-calcific plaque with spotty calcification right here. Now, we did the flow reserve quantitative perfusion with cardiac MRI, and the flow reserve is 6 times in the first patient, the one on the statin, and the second patient, the 42-year-old male, had 1.84. The normal, as I said, is 3 to 4. And note that this patient was not started on statin. LDL was actually 60 for this patient. And this was a clue that, the plaque characteristics are maybe indicating some kind of a flow parameters as well. So the relationship between plaque and perfusion is complex. Now here is another patient, 63-year-old, with chest pain on exertion. Now, there are three, we're showing here the LAD with the plaque here, and then there's in the inset is the diagonal branch, and which has a complex plaque, and then a mild plaque in the circumflex, and some more plaque in the right coronary. The question is, which plaque should we be most concerned with? I mean, we know that the more the vessels that have obstructive coronary artery disease, the higher the risk of adverse coronary events. However, we also know that the presence of any plaque confers increased risk compared to normals. So there's something within the plaque. They do matter, the plaque characteristics. So let me talk a little bit about what are high-risk plaques. And this is the standard definition when we look at CT imaging about high-risk plaque. Of course, stenosis greater than 50% we know is increased risk. This is positive remodeling, meaning the vessel is expanding to accommodate the increasing amount of plaque. Low Hounsfield units, which is defined as less than 30 Hounsfield units, is lipid. That's what we're recognizing here. Napkin ring sign is indicative of vulnerable thin cap fibroatheromatous plaque with a fibrous ring around, and then spotty calcification. These are the standard high-risk plaque features that we can pick up on CT. And we know that the probability of having acute coronary syndrome increases with high-grade stenosis. This has been proposed in 2008, and multiple studies have confirmed that. Particularly when you have more than two high-risk plaque features, the event rate starts increasing. What was also found consistently in multiple studies was not only the plaque features, but if the plaque is progressing, that significantly increases their hazard ratio of cardiac events. Now, going back to the previous patient, so we see multiple characteristics. We see high-grade stenosis. There's a lot of plaque burden. The disease is diffuse. There's both calcified and non-calcified. There's low attenuation plaque. There's also negative remodeling in this and a small lumen. And on the right coronary artery, it's moderate stenosis. The plaque burden is mild. It's diffuse, again, all along the RCA. Low attenuation plaque is also noted. There's negative remodeling and large lumen. Here on the diagonal branch, there's positive remodeling. So there's all kinds of high-risk plaques, and so which plaque is important, right? So from the confirmed study, we have an indication that perhaps the atherosclerosis is probably has a higher significance in terms of what confers risk. And the score actually used the diffuseness of the atherosclerosis, and they multiplied it by 9 times compared to the number of stenotic segments more than 50%. So it's starting to give us this risk score started to give us an indication perhaps that the atherosclerotic burden itself is more significant in terms of predicting risk. Now, this is a very interesting study that looked at credence, looked at ischemia. What is more important? Is it ischemia or plaque assessment? And what they did is a study that they took 618 patients and they did both CT imaging and perfusion imaging with nuclear stress testing and compared it with invasive FFR. And the common issue is that there's a concern that we have other exercise information with nuclear stress testing, and that also was integrated within the parameters. And in terms of CT imaging, in addition to stenosis, the plaque burden and FFR physiology information was included. And clearly, CT was the winner, and it was able to correlate better with invasive FFR compared to myocardial perfusion imaging, even including the functional parameters. I'm going to skip this one. So here, do all these plaques behave the same? So here you have some calcified plaques in patient A, and in patient C, you have non-calcified plaque, and then in patient E, we have plaque with spotty calcification. This is a much more diffusely calcified vessel with the higher plaque burden. And we have from ischemia study that looked at the hazard ratios of different plaque characteristics. This is a sub-study that showed that total plaque volume, presence of low-density plaque, and non-calcified plaque, number of high-risk plaques, diffuseness, and the remodeling index, all of them were had a higher hazard ratio. So the Credence study looked at not only stenosis severity, number of lesions more than 30%, non-calcified plaque volume, the lumen volume, and high-risk plaque features, and integrated that. And now we have some commercially available third-party processing software with AI that can integrate all of these multiple variables. As you can imagine, it's hard to know which one is important in each patient, and they are able to give us more patient-specific risk profile. And one of the important things that has come up is that beyond the stenosis severity and multiple vessel involvement, the plaque volume seems to be indicating which patients which will be getting future acute coronary syndromes. Now, this is another study, the ICONIC study, that looked at patients after a CTA and looked at plaque in patients who experienced acute coronary syndromes and the patients that did not. And what was noted was that the most of the acute coronary syndromes, 65%, occurred in patients with non-obstructive plaques. And of those, 129 plaques were identified as the culprit lesions. Again, 75% of them were in the non-obstructive plaques, less than 50% stenosis. When they looked at the quantitative assessment of the plaque volume, the total plaque volume did not change much between the two groups, or neither the calcified or fibrous. However, the fibrofatty plaque was much higher in the patients who had acute coronary syndromes, and so was the necrotic core. So we are able to measure this and predict that. More interestingly was that when they looked at all the different plaque features, not only was the necrotic core and fibrofatty pathologic, but what was also interesting was patients who had high density plaque, more than 1,000 Hounsfield units, they actually had less events. So the high density plaque may actually be protective. So not all calcific plaque is necessarily bad, and that leads to your point that you were making earlier. And so plaques that look different behave differently. Again, what matters the most in predicting future events, presence of high-risk plaque is much more predictive of future events, and presence of progression even compared to prior acute coronary syndromes. So the temporal, these are nice examples. Here's a 51-year-old patient treated with high-dose statins after the first study, and there is plaque regression in this patient. This is a second patient, again treated with high-dose statins. LDL cholesterol dropped from 137 to 62. And you see that the plaque is transforming with more calcification happening here in 2 years later. This is another woman with also, again, diffuse disease and was treated with statins. However, her plaque did not really regress that much. And she actually had plaque progression despite having the statins, and actually ended up having the STEMI. So this progression of the plaque can give us more insights into how these patients will behave. Now, as we mentioned, there's multiple features and factors. So artificial intelligence is now really being primarily used to integrate all of these data points to give us more individualized risk profile. And what was found was when you look at integrated data, that the rapid plaque progression was significantly correlated with the percent atheroma volume growing more than 1% per year. So can we modulate plaque progression? And as was previously mentioned, the Scott Hart study has already showed us that when you have the information from CT, there is a significant reduction in events because of increased use of statins and lifestyle changes. And the Paradigm study also looked at plaque composition, and in patients who have statins, the amount of calcification goes up and the amount of non-calcified plaque comes down. And there are other studies that have also looked at it. The icosapentail ethyl that has shown that there is reduced non-calcified plaque, and the evolocumab, which shows increased Hounsfield units of the density of the calcific plaque. And also with diet and in lifestyle changes, there's reduced non-calcified plaque and increased dense calcium. So with all these emerging therapies for prevention, it becomes more important to look at plaque. And so I would say that plaque imaging as a strategy can inform the clinician in many ways and guide effective management, including predicting the major adverse cardiac events, who benefits from CAP, who is not responding to medication and rapid disease progression. So commercial software is available, and I can show a couple of images. So these are, again, HeartFlow that gives you information on plaque volume and plaque composition. They also are able to give us information about where the patient falls within in a normogram. And I'm just going to show a couple more examples. So this is a female patient who, with the amount of plaque, she's at a higher risk, and the same, a different patient at a lower risk. So all of this information is being, and this is another commercial software that's giving us more plaque volume information. Again, these are not, these are expensive post-processing software, but they are available, and that's what's coming up next in the field. So.